Hello, everyone. My name is James Fitzgibbon. I'm one of the staff docs working at Cleveland Clinic main campus. I also work out at Hillcrest Hospital, and I'll be giving you a lecture today on point of care ultrasound in the emergency department for the abdominal aorta. Reviewing briefly our objectives after this lecture, we will have to talk about each of these, discussing indications for the abdominal aorta exam, understanding the pathophysiology and the development of aortic aneurysm. We'll describe how to perform the exam in detail. We will talk about the different anatomy you will see on an ultrasound view, and we'll talk about the pathology and what that looks like on an ultrasound view. So when doing any ultrasound in the emergency department, I always take a pause and discuss our indication as to why we're doing them. I was first taught years ago a nice mnemonic listed here, this I aim mnemonic, and going through this in detail when it respect to an abdominal aortic exam. An indication we'll be looking at someone with abdominal pain, risk factors for AAA, or perhaps part of a protocol such as the rush exam to identify a source of hypotension that's initially otherwise undifferentiated. We'll talk about the acquisition, about how we go about doing the scan itself, how the patient's laying, what probe we're going to use, how they might lie in bed, etc. The interpretation refers to knowing your landmarks, knowing what a normal image looks like, and then what defines a positive image, i.e., how big of a measurement is considered aneurysmal. And then M for medical decision making, what we're going to do with that information, and obviously if finding a positive, very significant aneurysm may involve a consult to vascular surgery. Screening guidelines for abdominal aortic aneurysm are listed here, and they help us understand who might be at risk for developing a AAA. Per USPSTF, it is actually a grade B recommendation for anyone who's a 65 to 75-year-old male that has ever smoked. Additionally, folks with additional risk factors may actually consider screening earlier. And so this risk factors are not surprising. Anyone that might put you at risk for otherwise other vascular disease, such as coronary artery disease, having already known peripheral vascular disease, or hypertension, can put you at risk as well for developing AAA. The types of aneurysm that will develop on the aorta appear on the left. A fusiform style aneurysm is the vast majority of aneurysm that we will see. Note that there are other types of aneurysm, such as a saccular aneurysm, but these are much less common. The size of the aneurysm matters, and this chart listed here shows you why. The risk of rupture incrementally goes up as the size of the aneurysm increases. An aneurysm of 4 centimeters or less has a risk of rupture less than 2% per year. As you go from 4 to 5 to 6 to 7, you can see that over 7 has a greater than 20% risk of rupture over the year. Typical guidelines will recommend consult to vascular surgery around 4.5, and usually folks are scheduled for repair as that grows larger, greater than, say, roughly 5.5 centimeters. The risk of rupture is guided by the physics principle in Laplace's Law, which we'll go through on the next slide. As you see here in this diagram, Laplace's Law is listed as the wall tension being directly proportional to the transmural pressure and the radius of that vessel. Thus, the tension as demonstrated here is going to be directly proportional to that radius size. So as an aneurysm grows larger and larger and larger, that wall tension needed to contain the blood within that blood vessel is going to grow. Thus, your risk of rupture will increase and be directly proportional to the size of your aneurysm. How you perform a scan is shown here. We're going to be using the curvilinear probe shown at the top right. As a reminder, This is a probe that has lower frequency and thus has better penetration. You're going to want to get this in two views, the short axis view as well as the long axis view. This is important to distinguish different artifacts that you may see, as well if frankly, if you're billing for this, you must have saved two images. You're going to want to measure from outer to outer, and your normal size of an aorta should be roughly less than 2 centimeters. Anything that is greater than 3 centimeters is considered aneurysmal, and anything between 2 to 3 is considered ectatic. Your probe will be positioned on the patient as follows. You'll start in a subxiphoid view with the probe towards the patient's right. Moving from that subxiphoid area, you will start to sweep down the abdomen sequentially all the way to the bifurcation of the aorta. Then you'll put the probe into a long axis view with the leading edge up towards the head to obtain the long axis view. We'll show you what those views look like on the coming slides. Your normal views are identified by some key landmarks. You're first looking at the top of the abdominal aorta around the celiac trunk. You'll next move on and identify the SMA, and then you'll want to move down to where the aorta bifurcates in order to get the full extent of the abdominal aorta. This still image here shows your first key landmark of the celiac trunk. Your aorta here is labeled, and you'll see this celiac trunk coming off and traced here, and veering off heading towards the liver is the hepatic artery on the patient's right. Heading towards patient's left is the splenic artery. This sign has been described as the seagull sign, given its appearance. Moving down, you will see in this image here what a video of that looks like. You can see nicely coming into view that seagull sign back and forth. Next on this still image, you'll see what the SMA looks like. Again, the aorta is labeled here. I noted posteriorly, you'll see beneath the aorta a hyperechoic sign here of the spine that can help you identify where your aorta is located. Not labeled, but in this region will be the IVC. Depending on how hard you're compressing, you can have this shape somewhat distorted. Here the SMA is just above the aorta and has this thick hyperechoic wall around it. Just above the SMA to help you identify, you may notice again, depending on how hydrated your patient is or how hard you're pressing on the patient, will be the splenic vein coming across above the SMA, ultimately joining with the IMV that is not viewed in this plane to join and make the portal confluence. Just above the portal confluence, you may notice in a patient, you'll be able to see at times the pancreas in this region. The next view, as you continue to sweep down the abdomen, will be the aortic bifurcation. You'll see the aorta roughly here, and again, with the spine shadow posteriorly hyperechoic with a dark shadow shown here. The aorta will split into the right and left iliac veins. And again, the IVC is labeled over here. Video of the aortic bifurcation is shown here. This image here shows the long axis view and labels anatomy accordingly. You have the abdominal aorta in the long axis view with this schematic showing that the probe is oriented up towards the patient's head. You'll note how the celiac artery has this nearly 90-degree takeoff, whereas the SMA has a takeoff that quickly then goes down towards the patient's feet. And you can see just how close proximity the two vessels are in one another from their takeoff from the aorta. Now, looking at the abnormal views on the coming slides, we'll show you a short and long axis views. And again, we'll demonstrate the key concept of to measure the size of the aorta is from the outer wall to outer wall. We'll show on this slide, the image is showing the very large abdominal aorta here in the center of your screen. I'll play this video again for you so you can see and start to drill into your head what an pathologic view of the aorta looks like. As you go through the video one more time, notice where you see the spine posteriorly as well as to the left on the screen seeing the IVC. Here on this next slide, we see the pathologic view of the same aorta in a long axis view. I'll show the image one more time. Again, you can see the long axis view of a pathologic aorta. On this slide here, we're measuring the aorta. Again, note that we're measuring from outer to outer and not with the thrombus within the walls of the intramural thrombus. Demonstrating here, you can see the intramural thrombus on the inside of this wall, and where we're actually measuring is from outer wall to outer wall, and here again, outer wall to outer wall with measurements shown at the top of the screen. On the long axis view, you can see again we're measuring from outer wall to outer wall and demonstrating a concept. You notice that the measurements that we're obtaining are slightly different in each of the views. You can imagine that based on the plane which you are measuring in the long axis view versus the short axis view, a long axis view, you may tend to underestimate the size of the aortic aneurysm, given that you may not be in the very center of the vessel. Conversely, in a short axis view, if you're not perpendicular directly to the aorta, but rather in more of an ovaloid type cut, you may actually overestimate. It's good to obtain measurements in the different views and consider an approximate average of the different measurements. This is a CT image of the same abdominal aortic aneurysm patient, again, demonstrating the aneurysm itself and then the actual lumen through which the contrast passed through the vessel. If you have any questions on how to perform the scan, just please go ahead and reach out to me at email listed here. And if you have any questions or references that you'd like to look for as far as performing the scan, I highly encourage you to look towards my materials. Good luck and happy aorta scanning.